Hi, folks. I see you all streaming in here this morning. So give us a couple of minutes and we'll get started. Thanks for joining us on this beautiful day in sunny Southern California. As always, a beautiful day in San Clemente. We're going to give it another 2 minutes. We'll probably start about 10:02 and begin our panel presentation discussion. I just want to give folks a chance to work out any of their technical issues as they get into the webinar and join us today for the conversation. If you're just joining us, we'll get started in just another minute here. I want to give a chance for the public to be able to sufficiently connect their audio devices for our webinar. So we'll get started here momentarily. All right. San Clemente, let's get started. Thank you all for being here this morning. And my name is Ryder Smith. I am work with the city and I'm here today to play the role of kind of MC or facilitator for our brilliant panel members to have a healthy community conversation and discussion about healthcare services in general and some specifics, obviously, to the city of San Clemente. So I appreciate you all being here this morning on a Saturday. A couple of notes to just remind you of. First of all, because we're trying to make this conversation move along swiftly, we're going to make sure that we have cameras on for our panel members, and we've kept cameras off for the audience. And we also want to have you direct your questions using a Q&A feature that's here. Importantly, today's session is being recorded, and we're recording this session because while we have an audience this morning to participate and submit questions, and indeed we made the ability to submit questions previously available, and so we have some questions already in the can. We also know that a lot of members of the public may not be able to get a chance to watch us, and through the power of the internet, we are going to use this recording to make it available to folks long after today's meeting so they can watch it at their own time and leisure and hear what our expert panel members have to say. So the hence it's being recorded. Let's go to the next slide. So as we noted, we'll begin with answering questions that have been received by email. We'll try to address as many questions as possible. And part of the point of using the Q&A feature is to just be efficient because we do have a hard stop today at around 11:30, and we're going to go for about an hour and a half and then get on with it. If we can't get to any of the questions today, we'll try to address them in our online FAQ. And of course, as I said, this video will be available for people to look at. Next slide. And with that, I would like to invite our mayor from San Clemente to offer a couple thoughts. Mayor James.
Thank you, Ryder. First, I want to welcome everyone to this April 9th. 2022 healthcare discussion, and this is just part of our community engagement in this endeavor. So I would like to thank everyone, all the participants that are here today, and I would also like to thank our panelists of experts, and I look forward to a fruitful conversation.
Thank you, Mayor James. I appreciate you being here today to help lead us in this question charge. Oh, sorry, I apologize. I think I might have stomped on you there because of a slight delay in the connection. As the mayor said, it's great to have you here this morning. And obviously to show up at 10 o'clock in the morning on a Saturday, you are committed to and being interested in this issue, and we really appreciate that. So today we're going to be talking about healthcare in San Clemente. We're going to start with about a 6-minute video that has been available in the wild now for about a week. We've had it, the city posted on its website, on social media platforms. because we wanted to really have a succinct way of talking about where we've been so far with healthcare services in the city. So we're going to play that video. It's going to last about 6 minutes. And then when the video is over, we're going to introduce our panel members and then engage in our Q&A conversation. So Sydney, with that, would you mind rolling the tape, so to speak?
Since 1928, San Clemente has offered the quintessential Southern California lifestyle. Now home to nearly 70,000 people and a destination for thousands of visitors, we are always looking for ways to make our town even better. An area of improvement our residents have identified is the type of local health care options. In a recent city survey, most residents understand our town does not have a hospital, but not many residents understand how much effort the city has made to recruit a new hospital provider to San Clemente. While 83% of survey respondents are in favor of creating a new hospital in San Clemente, and many would even support the use of taxpayer funds to build a local hospital, it is critical to understand the city's history on these important issues before we can work together to find solutions to what so many say is an unmet need. In 2014, Memorial Care Health Systems informed the city that they were exploring the opportunity to transition their San Clemente Hospital at 654 Camino de los Mares into a healthcare campus refocused on outpatient health and wellness services. The city responded by creating a hospital advisory committee to conduct further research and educate the community on Memorial Care's intentions. Over the next year, the community rallied together to fight against the closure of San Clemente Hospital, citing the local need for an emergency room. Ultimately, in 2015, Memorial Care made the decision to transition the campus to an advanced urgent care facility with outpatient and wellness services. The local hospital closed on May 31st, 2016. The city's reaction to this decision was multifaceted. In 2015, state legislation was introduced by San Clemente's state legislators, Senator Pat Bates and Assemblyman Bill Breaux, to allow for a freestanding emergency room in San Clemente. In California, it is illegal to operate freestanding emergency rooms. Emergency rooms must be part of a full-service hospital. Memorial Care was open to this remedy, but the legislation could not garner enough support, so the state's prohibition remains to this day. In 2016, the city of San Clemente changed the land use designation of the former hospital site, which would encourage the maintenance of the hospital and establish a regional hospital zone. Memorial Care claimed this action was an infringement on their rights as property owners. The city of San Clemente evaluated the financial feasibility of costs associated with remodeling or rebuilding the existing hospital building on the Memorial Care property and annual cost of operating that remodeled hospital with an emergency room. The evaluation included consultations with other healthcare providers to recruit another provider to San Clemente who would purchase the San Clemente hospital site and pledge to operate a hospital with an emergency room. Current and former San Clemente council members met with numerous nationally recognized healthcare systems. While all healthcare systems saw the value of our community, none believed their healthcare system could create a financially viable operational model. The city explored other publicly owned properties in the city of San Clemente on which a new hospital could be built. Then in 2020, the city published a request for proposals, RFP, seeking a contractor to partner with the city to redevelop and operate an acute care facility at the former hospital site. The city received a couple letters of interest, but not a single proposal. After tours of the former hospital site, both parties that submitted a letter of interest determined this: that rehabilitating the facility was infeasible and operators would not take on costs for new construction. Additionally, during this process, the city's research showed the possibility of acquiring the property to be cost prohibitive due to high litigation costs. The city met with other California public hospital districts to research the process for building and operating a local hospital with public funds and within the parameters of a California public hospital district. The City Council Hospital Subcommittee has worked to reestablish a positive relationship with Memorial Care Health Systems. That effort paved the way to reduce costs that the city would have otherwise incurred as a result of a June 2019 settlement of all litigation with Memorial Care. In that legal settlement, the city agreed to restore the previous zoning to the Camino de los Mares property. So where do we go from here? The recent survey on attitudes towards the local availability of quality healthcare showed that the majority of residents continue to want to have a local emergency room and hospital in town. It is clear from the years spent trying to recruit another healthcare system that a local hospital would have to be built and operated at public expense. Not only would taxpayer funds need to be used to build a hospital, but history has shown that operational costs would be borne by the San Clemente taxpayer as well. As we think about the future of healthcare in San Clemente, it is clear we need to engage in a new, robust community conversation about alternative healthcare options that would meet our residents' needs. As we do, there are 5 things our community must consider together. The abundant research and assertive action already undertaken by the city from 2014 to today. How emergency healthcare services are currently being provided to San Clemente residents. The risks and benefits of publicly funding and operating a public hospital. Consideration of new additional healthcare services now being provided in town by private healthcare systems. How healthcare innovations have changed the way healthcare is provided. So, what can you do to be a part of this important community conversation? Register your interest in this topic and sign up for relevant updates and news by emailing us, healthcare@san-clemente.org. Participate in the upcoming public meetings on this important topic. Share this video with your friends and neighbors. It's time for our community to come together to build a future in which we are all confident in our access to quality healthcare. San Clemente is a wonderful place to call home, and together, we can make it even better.
All right, and you will find that video online for the city. And I encourage you to share with your neighbors and friends and on social media too, just because we think it provides a good foundational start for a conversation, understand where we're at and help advance conversations like the one we're going to have today with our esteemed panel members. So real quick, I'm going to name off each panel member that I have my order here. I am confident I will mess up one or a couple of these names, and my apologies in advance, no disrespect intended. And then from this point on, I'll probably just use your first names. But first off, and then if you could just introduce yourself and talk about what you do or what your role is. This one may be obvious to the audience, but we'll start with it anyways. Mayor Gene James.
Good morning, everyone. My role in the past 2.5 years has been a member of the hospital subcommittee. Myself and former council member Ham, and now Council Mayor Pro Tem Chris Duncan, we are the guys that have spent a lot of time talking with people who had interest in the hospital, and that's what we've done in the last 2.5 years. And I look forward to this panel discussion because I need to learn even more. Thank you very much.
Great. And Mayor Pro Tem Chris Duncan.
Yeah. Thank you, Ryder. Thank you to those who are joining and those who will watch later on this nice, beautiful Saturday. I'm sure that people have a lot of things going on. Incredibly important conversation. I have had the honor of serving with Mayor Gene James on the hospital subcommittee, and after Chris Ham, I guess Chris is a requirement if you want to be on the subcommittee along with Gene. But yeah, I mean, really, my goal is to move the ball forward, make progress, and be responsive to what the public needs are within the constraints of what's best for the city. That's been our singular goal, and I think we've moved the ball down the field in that direction. This is a great opportunity to really kickstart the discussion with the public, though, and get that public input and be able to understand where everyone's coming from, and then adjust our policy based on that direction, again, keeping in mind what is possible and what is a prudent decision within the confines of the city's finances. And I look forward to hearing all of the input and commentary that folks will have today. Thank you.
Great. And I think to your point that you make there, part of having this panel today is I don't claim to know a lot about healthcare, and which puts me in a good position here of trying to be of hopefully asking some questions that are insightful for others as they want to think about them. And obviously we have the Q&A featured, but we have some panel members here who really talk about some of these complexities, which we got into already in an earlier conversation today about some of these things. Tammy McConnell, what's your role?
Good morning, and thank you for having me. I'm the Emergency Medical Services Director for the county EMS system, and what we do is establish and oversee the medical protocols that the ambulance and paramedic providers carry out when they are taking care of patients in the back of an ambulance. That also extends to the receiving hospital system. So we also regulate the trauma, cardiac, stroke, children's receiving centers to make sure that patients are being sent to the right place and are getting the right care. So I am pleased to be on this, and we'll be able to share some pretty meaningful data for San Clemente.
Great. And Randy Black.
Good morning, everybody. Thanks for having us. And dovetailing right behind Tammy is perfect, because what my job is at OCFA is to make sure that all of us are complying with all of the rules and regulations that Tammy has in place. We do a really good job at it. We are very efficient, and I look forward to trying to address any questions that might happen. I don't want to introduce Rob Capobianco, but Rob Capobianco is your division chief. He knows all of the nuances that are within the San Clemente system, and we'll be hearing from him, I'm sure, later in this presentation. Thank you very much.
Well, thank you for that. Thanks for doing my job, Randy. I appreciate it. Rob, why don't you introduce yourself?
Good morning. Thank you for having us. I'm Rob Capobianco. I'm a division chief with Orange County Fire Authority. I kind of serve as your local fire chief. I'm the liaison between the city and our fire chief, Brian Fennessy. So on a daily basis, I work with your city manager, Eric Sund, as well as our board of director, Kathy Ward, addressing and dealing any fire concerns. We are the not only fire, but also the EMS provider for the city of San Clemente, the ALS, as well as or advanced life support, which is your paramedic provider for the city of San Clemente.
Awesome. Thank you. And then we're going to turn to a couple people who are experts in the field of hospitals and hospital operations. So Paul Young, you want to introduce yourself?
Sure. Thank you, Ryder. So good morning, everyone. Paul Young. I'm the Senior Vice President of Public Policy and Reimbursement at the Hospital Association of Southern California. We represent hospitals across with a regional hospital association that represents 6 different counties. So that's Santa Barbara, Ventura, Los Angeles, Orange, Riverside, and San Bernardino. So hospitals operating within those 6 counties are members of our association. And I always like to put it out there that please do not confuse me with the British pop singer of the 1980s, 1990s. That's not me.
I was going to ask you to sing as part of the panel today, so I'm glad you stopped me before I made that request. And last but not least is Tatiana Popkova.
Good morning, everyone, and thank you for having me today. Look forward learning more about San Clemente community and how we can support and help from our perspective. My role, my assignment at UCI Health is to support the organization as Chief Strategy Officer, building upon everything the other panelists just mentioned, and execute on our mission, which has 3 parts to it: clinical care for our communities, teaching the new generation of medical professionals, and providing world-class research and bringing that research back to our communities into clinical care as well, and telling our communities about what we do. So pretty simple job. Look forward to participating and supporting all of you.
Awesome. Well, my thanks to all our panel members. And as I said, I was able to rally them up to join us at 10 o'clock this morning for the conversation, with some promise that they would be able to get on with the rest of the day, which is why we're going to bring it to a close at 11:30. But let's get into some of our questions. So as I noted, we had some questions that were available to submit ahead of time, and that I want to make sure I touch upon. So I'm going to throw these out here. And of course, I'm going to encourage members of the public. I see some folks have already started submitting some questions. One reminder too, if you would like to submit a question anonymously, you certainly can do that. If you want to submit a question and actually have us call out your first name, last initial, I'm happy to do that too, just to give you some credit so you can know it was your question specifically that was asked. I'll also just say sometimes we see redundant questions come in which case we may bundle up a couple questions to a more generic, streamlined version of asking a similar question to really get to the point, we think, of what it is you're trying to get to. So I just understand if we don't read it verbatim, that is probably why. And like I said, we have hard stops. So if we don't get to your question today, we will try to cover it in future frequently asked questions on the city's websites and resources. First question. I think this will go to the mayor pro tem, and maybe out of deference for title, we'll start with the mayor's opportunity to respond first. But how has the hospital subcommittee improved the city's relationship with memorial care? Obviously, we just saw this video that talked about some of that history there. And what do you see as the ongoing role for the hospital subcommittee?
So I see our relationship with memorial care having improved considerably over the past year and a half. I think we started off with a relationship that may have been adversarial in nature, and certainly when you're in litigation, you're adversarial in nature. But I think we've hit a reset button with memorial care. I think we've established a relationship of trust with memorial care and two-way communication. We're still two separate entities with different objectives and different interests, but I think we've come to a place where we have mutual respect, mutual trust, and as one person, as one council member, I look forward to continuing to work with memorial care going into the future. What do I see the hospital subcommittee being in the future? I see it as continuing to look for the best healthcare options in this city. I think we can all agree that that is the objective of our subcommittee at this point. We may have different opinions on what that will look like going in the future, and this is why we're having this conversation today. And I look forward to the conversation we're going to have on April 23rd as well. Thank you, Ryder, for that question.
Yep. And Mayor Pro Tem?
Yeah, I'll just add on to a couple of Gene's points. So for memorial care, I would just say, I think at this point, again, we came to a settlement in the litigation. There are competing interests in some places. I see the relationship with memorial care as finding the commonality of interests and focusing on those. Where can we agree and make progress in those areas? There are some areas like that. So I think that's where we've gotten to, and it took a lot of work from Gene and I to repair the relationship somewhat. And so I think we're now at a place where we are focusing on those common interests and making progress there. On the subcommittee, I think what it is being receptive to San Clemente residents' needs in the healthcare area and setting policy that meets those needs. That's really what it comes down to.
All right, great. And then follow-up questions that are related points to this. Again, for the mayor pro tem, have additional healthcare facilities been developed in San Clemente since Memorial Care San Clemente campus closed in 2016? And are there any care facilities currently planned in the city that you're aware of or can speak to?
Certainly, we have several urgent care facilities that have been created since 2016 in the city. And currently, we have a project ongoing at the San Clemente outlets with Providence they've already received the grading permit, and they're moving forward with I believe it is a 7,500 square foot healthcare facility to include urgent care.
Okay, anything to add, Mayor Pro Tem?
Well, I would just sort of to kind of address that, maybe the real question. We don't have any plans for emergency services in the sense of an emergency room at this point, but there are other projects too, in addition to those mentioned, that provide other kind of health services. So I think what we really are looking for in the future is there something more than what we have or more than what's planned that is possible and reasonable, that would deliver additional needs of the community out there that haven't been addressed with what we have or what's planned.
And I think one clarifying note too here to make, because ultimately much of this is dependent upon market forces and response. It's in some ways why there were a change in the status of the memorial care facility. When you say we in terms of plans, where the we there is the city has not been made aware of a submitted proposal or development plan by a hospital, for example, to come in and operate.
It's a good point, and I want to make sure we round that out. And it was mentioned in the video. We have actively sought hospitals to come into San Clemente and partner with us to move forward with a hospital, full service hospital with emergency room services. No one has stepped forward and been willing to partner with us on that. And I think we need to make sure everyone's very clear on that. It's not for a lack of effort. We have really tried to solicit that interest and we have not gotten that. Yes. So Ryder, to close out that point, no, we don't have anyone who has proposed or even been willing to really firmly engage with us on how to move forward with a hospital at any location within the city.
Okay. Thank you for allowing me to clarify that and for your clarification on that response. All right. Some questions here for maybe our friends over at the county, Orange County, and their response. So in South Orange County, we have a regional emergency medical services model. Can you explain what a regional EMS the model is, and why we have that regional response model and how it works? So this is just a great high-level explainer, right? So let's educate the public about that. So I think maybe we want to start with Rob to answer that question.
Sure, I can speak to it. So what I'll speak to is the regional response and regional coverage that OCFA provides for the city of San Clemente. So like I said earlier, Orange County Fire Authority is not only your fire, but your ALS and your EMS contract for the city of San Clemente.
And sorry, can I interrupt, Rob? I'm gonna interrupt you when I hear acronyms. So yeah, EMS I assume is Emergency Medical Services.
That's correct. Sorry.
ALS is
Advanced Life Support. So you're
okay.
So Orange County Fire Authority is your paramedic provider for the city of San Clemente. That being said, the Orange County Fire Authority is a large regional agency, both for fire and EMS, serving 23 cities in Orange County, as well as the unincorporated areas of Orange County. So when you look at the regional aspect and the regional philosophy and how that applies to the city of San Clemente, it's a huge asset. San Clemente has some significant challenges just because the topography and the geography. You look at it's the end of the county, bordering up to San Diego, the ocean on one side, open space on the other. So really your help and your resources are coming from the north. So what that does and what we do with it, luckily back in 2017, as a response to the San Clemente hospital closure, we worked diligently with the city and were able to fund that third paramedic unit within the city. Prior to the closure, we had 2, now we have 3. All 3 of your fire stations have paramedics that can share and assist with that depth within the city. But more importantly, regionally, we look at outside that city, and we're constantly evaluating the coverage within the city of San Clemente. And why we're proactive with that is because the time it takes to get down to San Clemente because of your geography, we can't wait. So 1, whether it's a daily call load during the summer, or 2, we have a large incident, a structure fire or a wildland fire. Our emergency command center up in Irvine is constantly evaluating the coverage, and we're moving resources down to the city so that we can continue to run those back-to-back calls. And I can tell you from my years of watching the calls in San Clemente, it is not unheard of for San Clemente to have 2, 3, and even 4 calls going at the same time, where we're bringing multiple resources from our cities to the north in Dana Point and San Juan and Laguna Niguel. The other thing Orange County Fire Authority does is we have a strong automatic aid and mutual aid agreement, not only with our neighboring cities in Orange County, and we do utilize Laguna Beach quite a bit in South County, but even with Camp Pendleton down south of us. I know that we're different systems with San Diego versus Orange County on the pre-hospital care piece. But when it's in an emergency, we share resources, both fire as well as EMS when the need be, and those contracts are in place. So we're constantly evaluating the level of coverage within the city and moving up resources aggressively and taking advantage of that large regional resources.
It's good to have scale. Tammy, you want to follow up on those comments? I think, do you want to follow up on those comments?
Yep, I do. Because to complement what Rob said about the response and the coverage and the transport, you have to have a complementary hospital system in which to receive those patients. So in the county, we have geographically spaced specialty centers, emergency departments, stroke, cardiac trauma centers, in which patients are dispersed. It is not, these hospitals that elect to provide these types of services have invested millions of dollars in not only infrastructure and equipment, but also staff training. And this is part of what our office does, is to make sure that they are meeting those appropriate standards of care. So a regional model encompasses a lot of components, and a hospital specialty center is one of them. And I'll let you ask the next question.
All right. Yeah. So then I guess the follow-up question that we've heard around here that seemed relevant was, where are San Clemente patients experiencing emergencies taken for services currently? And I guess what would also be real helpful, because I was curious about this question when you and I were chatting before, like, how many calls are we actually talking about? How many times are we putting people in a hospital, and where are they going ultimately when they get in an ambulance or a paramedic unit or something along those lines?
Yeah, so just as before, the top two hospitals that San Clemente residents are taken to are Mission Hospital, Mission Viejo, and Mission Hospital, Laguna Beach. It pretty much 70% of all transports, or of all calls in San Clemente, are going to the Mission Viejo campus. And we're talking about annually 3,000 patients, and of those, about 2,000 are going to Mission Viejo. There are 3 other hospitals that are within 10 to 15 miles of San Clemente: Hoag Irvine, Kaiser Irvine, and Saddleback, Laguna Beach. Patients are also taken there. When we looked at the data, the patients are actually dispersed throughout the county. We even have patients going to Chalk Children's Hospital, going all the way up to South Coast and Santa Ana. And those typically are patient requests. And we work with OCFA and the ambulance companies to make sure that we, if it's appropriate, to make sure that we accommodate those requests.
So I guess I have a couple natural questions. If there's no particular request, what caused you to choose Laguna Beach over the Mission Viejo campus, for example?
So it depends on what's going on with the patient. So pretty much, and this is going to come later, if it's any type of cardiac, stroke, or trauma indication, those patients are going to go to Mission Viejo. When we looked at the data, about 25%, so about 750 patients actually went to the Laguna campus. So it just depends on the type of patient that and what's going on with them, because I believe those two hospitals are pretty equidistant, and it just depends on what end of the city you're on and where you're at.
Okay, so a number of some factors of geography, some factors of what actual service capabilities exist at those hospitals, because they're not necessarily directly comparable in terms of capacity. I see Mayor Pro Tem Duncan that you raised your hand. Did you have a comment you wanted to make?
I just had a follow-up question for clarification about what percentage of those patients would have gone to the San Clemente Hospital if it was there as a community hospital versus the trauma center at Mission Viejo or in Laguna Beach.
So, probably a good majority, because we did parse, because the majority, and this is a question for later, the majority of the transports are for non-acute, meaning they're not having a heart attack, they haven't chopped their finger off, they're not having any trouble breathing. So 70% of the calls are really for generic abdominal pain, weakness, that they need to be seen in an emergency department, but they could go to the closest, most available emergency room rather than a specialty center.
So roughly of
And,
those, so I guess to clarify a comment on that, you talked about there being about 3,000, roughly 70% of that, roughly 2,000. So 2,000 of those are non-acute transport cases.
I wouldn't call them non-acute. They just don't fall into the category of trauma, heart attack, stroke. They're other types of emergencies.
Okay. And sorry, and that's really important that we have these, there's a lot of definitions and words that get used in healthcare. And that's where I'm also fumbling a little bit on it, because I want to make sure I get it right. And we understand some of these terminologies and how these categories break down. So that's
well, and Ryder, I think it's important to note too, that prior to the San Clemente Hospital closure, those types of patients, trauma, heart attacks, trouble breathing, they were already being taken to the specialty center. So
meaning they were being taken to Mission Viejo, or they were being taken to Laguna?
Yeah.
Okay. So
this is Randy. I'm fully in line with what Tammy is saying. So the most acute calls were going somewhere else. San Clemente runs its own ambulance system. Therefore, if the low acuity calls are being taken to San Clemente Hospital, theoretically, that's a much closer destination, delivery, and back into service. I just want to point that out.
and I see, Rob, you raised your hand too. So did you have a comment you
Yeah,
want?
one other thing that I think can clarify what Mayor Pro Tem Duncan was asking, just looking at some numbers prior to the closure of San Clemente Hospital, it looks like about 70% of the transports from San Clemente were going to the old San Clemente Hospital. Now those numbers are being dispersed through the other area hospitals. And when you look at those 70%, that's that lower acuity to where your San Clemente ambulance contract is able to stay within the city of San Clemente. Does that answer your question?
I think it further enhances and reaffirms Tammy's data as well.
Yes. Thank you all for that.
Great. Actual numbers and data. I love numbers and data. Helps advance a conversation. Put it on context. It's a less than 10 emergency calls a day on average, 356 days a year, 3,000 calls for emergency response where somebody is actually transported. Is that a right number, Tammy? Less than 10 a day?
Sure. Yes.
Okay. On average. I'm sure people are more dangerous on the weekends. So probably on the weekends, the number goes up. All right. Let's see. Our next question, because did I get to my I asked you where San Clemente residents are, where they're taken. So we're good with that. Let's go to my next question. So about 83% surveyed by the city last year said they had supported bringing a new hospital with an emergency room to San Clemente. And that 57% said they were willing to even use taxpayer money to fund that new hospital. So, this is a public policy question. And obviously, there's some significant community interest. That's why we're doing these community forums. My question for Mayor and Mayor Pro Tem, what are the risks and benefits of building and operating a public hospital?
Chris, I'll let you take that. I'll let you take that first.
Thank you. Well, gosh, we have vigorously explored the possibility of a hospital, and it's clear we have residents who very strongly want a hospital. And actually, the poll showed they strongly want the hospital at the existing location. But financially, it's just not possible at this point. I don't know if I can say that more clearly. The city would have to bear essentially all of the financial risk, the financial outlay. Actually, the residents, through a bond, and then the residents would have to pay for the operation of the hospital. We didn't get any hospital operators that indicated that they would be willing, even if we built the hospital, to operate it without public public investment as well. So, I mean, I guess I would just say broadly, it's very difficult to see how the city could financially support a hospital at this point under the possibilities that we've been presented with. I'm not sure if Gene has more on that.
I couldn't agree more. The fact is, we would look at the very least at a $200 million bond. And some sources tell me at $200 million, we might very well be undercapitalized. We would then have to operate a hospital. And I would defer to our expert at UCI on this, but the model for healthcare, and also Mr. Young, the model for healthcare has moved away from the old inpatient care model, especially with insurance companies who try to push patients out of the hospitals as quickly as they can. And I'm told, really, you don't want to stay in a hospital a long time. So the old model of 10 years ago, 20 years ago, 30 years ago of inpatient care has moved considerably. You see where people are getting knee transplants, hip transplants on what is virtually outpatient surgery. And, you know, I don't think a inpatient care in San Clemente is going to be financially viable. You know, we are at the mercy of the forces of the market. And I truly feel that this would be a burden for our taxpayers. And Chris called them residents. I'm going to call them taxpayers. It's going to be a true burden on our taxpayer to have this $200 million bond, which might very well be undercapitalized, and then still have to operate a hospital without losing money. So I see that as the risk. And additionally, one other thing I would say, we had a poll, and the one thing I wish that had been asked in the poll is, would you give up your current healthcare provider, your current healthcare system, to use a hospital in San Clemente? And I fear that answer would be, for many, would be no. And, you know, your primary care physician is a very personal relationship you have. And that primary care physician is usually attached to some healthcare system. And are you going to give up that primary care physician to use a hospital in San Clemente? And I don't know the answer to that, but rolling the dice on a $200 million investment is very troubling for me. Thank you.
If I could just close out again, Ryder, I mean, I just want to make crystal clear. Both Mayor James and I tried as hard as we could to attract a hospital here. We both heard the residents, the taxpayers. They wanted a hospital. We knew that before the poll came out. But we can't force a business to want to come and operate in our city. And we just didn't get anyone who was willing to make that financial investment. They wanted the city to bear essentially 100% of the risk, and then not even guarantee us that even that we had the hospital, they would come in and operate it. They wanted to see it first, essentially. That's just not a good use of taxpayer funds to go down that road. And so this is the position we find ourselves in. And that's why I'm really interested in hearing more from the panel too about what other options may be out there. And if there's some other option for a hospital, I'm certainly willing to hear it, but we've been chasing this down for years now. And it's very apparent in the hospital community that we are looking for a hospital to come, and we have not gotten anyone to dance with us, essentially.
No. Okay. Well, speaking of which, let's turn to some of our other panel members, because I got a couple other questions here that can speak to some of those points and also talk about distribution of emergency care services. And then we're going to transition. I got a question here that I suspect Tatiana and Paul will be excellent at answering as well. So the question I'd have, I'll go back to our county folks. What kind of a medical emergency is the most prevalent in San Clemente? are most of OCFA calls for trip and fall, heart attack, stroke? And you started speaking to some of this, Tammy. So I'll let you kind of maybe be redundant with some of your answers there, but we can also explore with a couple follow-up questions too, I suspect. And you're muted, Tammy.
Take the second question. That the answer is no. Not the majority are not falls, heart attacks, or strokes. The majority are what we call medical problems: abdominal pain, weakness, seizures, diabetic issues, either high or low blood sugar. That accounts for about 32% of those, that 3,000 number. The second category is even more generic. It's no illness, I just don't feel right, general weakness, pain, burns, lacerations. Actually, that's third. So the majority are really generic medical problems that do require a paramedic assessment, but then they don't require transport to a specialty care center. I did want to point out that what we see out of the 3,000 transports out of San Clemente, only about 4% or 100 patients are in that cardiac chest pain category that would then go to Mission Hospital, Mission Viejo. And then strokes account for even less, at about 30 patients a year. And again, those would go to Mission Viejo. So those aren't the most prevalent conditions. And I just want to reiterate too that those calls prior to San Clemente closing did not go to the San Clemente Hospital. They were already going to the specialty center.
Okay. A related question, and maybe Paul has some additional data on this, but I saw a question that was also floated from the public here. I think Stephen C. had raised a question or point that the prior emergency room that was in the city had been seeing perhaps as many as 15,000 patients annually. I am just curious. So there are people, I guess part of the point here is not everybody's transported in a Orange County, or a County of Orange ambulance or hospital, right? So you're only talking about the 3,000 that actually get transport.
Right.
So first point, there are lots of calls you respond to that nobody's transported, correct?
Oh, yes.
Yes. So that's, I assume, even a lot more than 3,000 a year.
About 4,600.
Okay. So another 4,600, there's no transport, but you respond and obviously deliver services on site, whatever it may be, and then they can take it from there in terms of transport. And then a related question then is, how do we account for people who are walk-ins or who self-transport to get to the emergency room? And maybe you or Paul can talk about that?
Yeah, so we have a different data set that we look at, Ryder. I mean, it would include obviously the EMS transports. But in terms of overall utilization by city of residents, I mean, so city of San Clemente residents incur roughly about 11,000 emergency room visits, right? That's dispersed throughout the county, predominantly at Mission Viejo or Laguna. But so if you take a look at roughly 11,000 ED visits, again, and then roughly about 5,000 inpatient admissions are from residents of San Clemente. I would also, in light of Mayor James's comments, the inpatient utilization for residents has declined over the years. I can go back to 2016. It was closer to 6,000, and we're down to 5,000 in 2019. And I'm using 2019 because it's pre-COVID, so it's a little more consistent, right? When we look at 2020, that's sort of like a throwaway year in terms of utilization because of the disruptions that the pandemic created. So, I mean, we're already on a downward trend in terms of utilization, right, from 2016 to 2019. It's anyone's guess is what the 2021 data will start to look at. We haven't actually seen that yet. It's not publicly available.
Is it a fair statement to also say that population in San Clemente has increased over that same period of time? So perhaps even creating a further gap between utilization and theoretical customer base?
Yeah, I haven't looked at the overall population counts, so if we looked at, let's say, in order to standardize the numbers in terms of like ED visits per thousand, I didn't do that calculation, unfortunately. I'd have to look at Mayor James or Pro Tem Chris about, if the numbers in terms of population.
I assume your Mayor Pro Tem, your population numbers have increased over the last 3 or 4 years. Is that a fair statement?
This is Randy, OCFA. I just want to also point out, San Clemente is running their own BLS or 911 ambulance response system. So when we talk about where the patients go, how far the destination is, I don't have the numbers at hand. Chief Capobianco can get those for you. But there is a piece to this that is about BLS as well.
Could you again remind us of the BLS term?
Oh, okay, basic life support and advanced life support. I think Ms. McConnell was spot on. Her numbers are probably extremely accurate. We would transport a large number of advanced life support patients to locations other than San Clemente Hospital. But you're running your own ambulance system in the city of San Clemente. And if the other percentage of those patients could go and stay within the city of San Clemente, therefore reducing transport times and response times, I think that's something to look at as policymakers. I don't want to get into your policy making decisions, but I think there's something there that would, I'm confident it would enhance the EMS delivery system for OCFA. But I think for you on a micro level would also take a look at the contract that you have for your ambulances. And I'll leave it at that. I mean, there's a lot of discussion, a lot of data, much more that needs to be looked at for that. But I just want to throw that out.
And indeed, I think that's that data and those complex issues are exactly why we have a subcommittee working on these issues, and we're having this community conversation too. So thank you for that, Randy. Mayor James, I see you raise your hand.
Certainly. Our ambulance service, that is a completely different topic that should be discussed a different day. And we're continuously looking at that possibility of how we're going to change that in the future. That's my first point. My second point is we simply cannot look at a hospital, at an emergency room standing alone. We have to look at the fact we would have to build a hospital in conjunction with that emergency room in accordance with California law. And that's where we will run into problems in trying to run a hospital that at the very least is not going to cost the taxpayer money. Hopefully would make money, but I don't see that. I don't see inpatient care being a money maker, and I see inpatient care as being a significant drag on the taxpayers of San Clemente. Thank you.
So I think maybe this speaks to some of the data that Paul had shared from the Hospital Association perspective, and I'm going to divert a bit here, and I want to just pursue this question, which is declining inpatient services at hospitals can leave some stranded asset costs when you got a underutilized inpatient hospital. Again, we'll ignore COVID, which obviously totally changed the world. I am just curious, is that one of the broader challenges hospitals are seeing in terms of their inpatient versus emergency room services and how they're handling that infrastructure for maybe lower utilization on inpatient services? And I think that inpatient, to the prior point, inpatient service utilization at hospitals is dropping because more and more services can be done outside of a hospital to get things like a hip replacement or knee replacement or other services. So there's some assumptions in what I just said. I'll turn to our two hospital experts over here, Paul and Tatiana, to comment on that. Paul, you want to comment on that?
Sure. So, I mean, that's been the general push from payers, whether it's the federal government or even the state. I mean, everything is pushing to an outpatient environment. And that's why the trends are going where they are, right? So CMS, which is the Center for Medicare and Medicaid Services, they're the federal agency, basically, they're the big kahuna, right, in this equation. And they're basically pushing their Medicare beneficiaries into an outpatient environment. So Mayor James brought it up. Yes, I mean, you see a lot of hip surgeries done on a same-day surgery now. They're no longer being done in an inpatient setting. Why? Because of cost, right? The federal government doesn't want to pay for an inpatient stay if they can basically pay for an outpatient surgery at a third to a quarter of the cost. And why is it more expensive in an inpatient setting? It's because of the regulation and labor costs. I mean, if we look at how much we spend labor-wise, I mean, most hospitals, over half of your budget is spent on wages and salary, right? Because we're a 24/7 operation, right? When you talk about running an ER, it's not just the ER. You've got a hospital has 8 basic services that you've got to run. There's a huge environmental services and infection control, as well as compliance-related costs. And Mayor James, in terms of 200 million, I think you're shortchanging. Whatever that cost estimate is, probably shortchanging. I mean, if you just look at the EMR, the electronic medical records system cost that you probably need to incur, I mean, that's probably another $50 to $70 million, just right there. And in terms of the implementation, but then the ongoing costs, right, operational on an annual basis. It's a tough run. I mean, and I would say, 40% of our hospitals, unfortunately, are in the red on any given year. We're not hospitals are not profitable across the board. And Tatiana, I'd kind of open it up to you, and Chris, I see your hand up. So
Tatiana, why don't you comment on that, and then Mayor Pro Tem, if I can come back to you, I want to give Tatiana a chance to chime in. We've held her at bay for 57 minutes, so I need to give her a chance to say something brilliant.
Well, I don't think I would say anything different, and I will build on everything that my colleagues on the panel been addressing. Specifically, Paul, thank you for bringing the cost element of this. What I can add is that when you look at it also from the patient, consumer, community member view, is what we see is that over the last 10 years, in addition to what Paul mentioned, the cost, the payer, ambulatory, I shouldn't say ambulatory, probably the drive towards outpatient environment. One of the reasons we're creating the business models and operations that are beyond hospital, or we call it hospital without walls anymore. We're trying to see how we can deliver that level of care into your home via digital health to make sure that only the sickest of the sick come in the environment that others describe, because it is very, very expensive to treat patients in the inpatient environment. So the right care at the right time and right space is definitely something that also consumer and patient centric, because if you don't need to be in that environment and be able to deliver safe, appropriate care, and just through escalation, handoff, good collaboration, public-private sometimes collaborations with AMT services, emergency services, and others to make sure that you stabilize, you get that care in the setting like your home, like outpatient. I think the hospitals have a limited need and the presence in communities. That has been the trend around the country, not only California.
I guess can we just talk, because Paul, you had made some comments earlier when we were chatting in preparation for this conversation, so I had some background information since I'm coming at this as an ignoramus. You had made some general comments about there wasn't a lot of innovation in the hospital space until like 2010 era or something like that, in the Affordable Care Act. Can you just talk a little bit more about what's really spurned that and the impact of the Center for Medicaid, Medicare, I believe is the terminology used. That's where a big chunk of the money actually funds hospitals, if I'm correct, and supports them. So can you just explain to folks how that innovation, where those innovation gates are, what the pacing of innovation looks like, and kind of reaffirm some of the observations Tatiana was sharing?
So because of federal regulation, I think the term I used was glacial in terms of innovation. The Affordable Care Act did actually start what's called a CMS Center for Innovation. And that's where the federal government really started to try and start to test through their what's called a waiver process, the ability to look at things like the Tatiana just brought up the Hospital Without Walls. It's called a Hospital at Home program. That's sort of like one of their latest innovations that's born actually out of the pandemic. So this is more of a 2020-ish innovation that they're allowing. And it's definitely something I think that hospitals are looking at, because she's exactly right. I mean, in terms of patient preference, you'd rather be taken care of in the home, not in a strange, hospital that's, I mean, how many of us have actually been admitted, right? And want to stay in a hospital 24/7? No, you'd rather be treated at home with where your family is. But yes, yeah, in terms of the overall regulatory environment, we tend to kind of go in spurts and starts. The feds tend not to be very innovative. And I'll leave it at that. I know Chris has been chomping at the bit here to comment.
Chris, you've been champing at the bit. You want to ask your question? You're muted.
Sorry, yeah, no, not chomping at the bit. Really, actually enjoying and learning the conversation. It sounds like actually we have a consensus from our experts, and that was really the point of this. So I think we can stop right here. No, I'm just kidding. That was really informative to hear. I just wanted to close out some of the comments. We've been talking about financials, and I want to make sure we're crystal clear about this, and I'll be as precise as I can. We did a request for proposals for the old property site. We got very limited interest from any hospital operators for the old site. At the old site, amongst the reasons why it was cost prohibitive and it's not taken into account is you'd have the 20 some odd million legal fees to do the eminent domain action. Then you have to buy the property at whatever the court determines is the fair market value. Then you have to probably raise the property. That's what we heard from all of the different hospital groups before you ever build anything. Now, once you start building, we understood it's 5, 10, I don't know, maybe longer than that before you actually get a hospital with all of the construction and then the permitting you have to get for all of the, and we can have Paul maybe speak to some of that in terms of the timeline. If you started building today, when could you expect to actually get a hospital? I mean, these are just, again, I should have premised, Mayor James and I, we were very strongly wanted to get a hospital when we start this process. That was our #1 goal. But the financials of the old site really don't make any sense. Now you start looking at other sites. Okay, well, we have limited sites that are big enough with city property. Thing to remember there is if you give a property away for $1 or for free, it's not just that you're giving that property away, you're giving away the $15, $20 million of value of that property. So tack that on to the cost. Then you're building, that you could have had something that was a revenue generator there. Now you're building a hospital. So I just think, I mean, I hope people can take this into account. It's not like we were just trying to close the door on this. The financials just don't make sense. And then you add on what we just heard from our experts about the practicality of operating. I think this is why we got the limited interest, right, Gene? I mean, so these operators came in to talk about the old property, but then we talked about other locations, right? We use that to say, what about other locations? Some of them are hospital districts. To address that point, they wanted the city to do all of the lifting. And even then, again, there was no guarantee they'd come in and operate it because, again, they're looking at these same financial constraints that Paul and Tatiana were talking about. So I hope we can move on from that and folks understand the financials in the market they don't drive this in the direction of a hospital. So I hope we can turn the discussion to what else out there is feasible for San Clemente to meet the needs of the community. Thanks.
And I think to your point, Mayor Pro Tem, the broader context of this conversation today and the conversation we intend to have with the community over the coming weeks is to have all those things on the table and have a conversation about it, some of which there are questions worth pursuing about why would the hospital market not respond to deliver in the city, and how, and understanding the history of what efforts were made to deliver that, as well as talking about some of the other new models that are changing. Because this is my first time ever getting talked to hospital operators, so it's good to be able to talk to them and ask them like what the market realities are, what challenges they're facing. Mayor James, I see your hand up. Did you have an additional follow-up?
Yeah, I just want to follow up on a couple of things Chris said. Everything Chris says, I agree with. we both went into this wanting a hospital, absolutely wanting a hospital in San Clemente. Number one, a very popular political perspective to have. But the more we got into it, the more we realized, and to Mr. Young's point, I fully agree, $200 million would probably have us severely undercapitalized. To go through a condemnation process with Memorial Care. I will defer to Mayor Pro Tem, who's an accomplished attorney, but I believe whatever the court would determine the fair market value of that property would be, we'd actually have to put that amount of money up front into an escrow account. And I don't know where that money would come. I really don't know where that money would come from. So we have tried everything. And we have spoken with people who said, UCI is very interested. Well, we called Tatiana's boss and he said, no, we're not. We'd like to help you do it, whatever you have to do in your community from a healthcare perspective, but we're not interested in inpatient care in San Clemente. We spoke with other providers, other noted institutions. They're not interested. They're interested in coming to San Clemente and providing some sort of healthcare alternatives for us, but they're simply not interested in running a hospital. We've spoken with charlatans who've come to us from out of state. There's a ranch term, all hat, no cattle. Well, these guys were all hat, no cattle. And, you know, we continue to look for what the best options are for healthcare in San Clemente. And that is where Chris and I have fallen. And that's what we want to do. Thank you, Ryder.
Yeah, fair enough. All right. Let me, so one of the questions that comes up a lot during all this conversation, I'm going to change a little bit of direction here. I suspect we'll be talking about hospitals going into the future. Just to put some more context and numbers on that for other people who'll be new when we do our next community forum in person, then I'm sure it'll be a source of discussion. But let's talk about some of the metrics, because we've had some really helpful metrics today. What is the current response times for emergency calls in San Clemente? So that would be, if you have some, that may be Tammy, I suspect that might be up your, no, okay. Rob, maybe it's up your alley?
Yeah, I can address that, at least from the OCFA's perspective. So I'm going to throw out a number, but I want to qualify it a little bit as to what it actually means to us. So once again, I spoke about the challenges that San Clemente creates with the geography and being down towards the bottom of the county. We've had two big challenges. When the hospital closed back in 2017, we added a paramedic unit. And then we've also had a big challenge with COVID. So we look at our response times. Every quarter, we send our response times to the city. And I can tell you what it is. Just for this year, our average response time is 6 minutes and 55 seconds. That's for the first unit to get on scene. Now, what does that actually mean? And to me, what's important is that number hasn't changed. So when you compare our response times to prior to the hospital closure, you compare our response times during the COVID surges, our response times haven't changed. And like I mentioned earlier, why have we been able to hold our response times after the closure of the hospital? And it's because the city added an extra paramedic unit. At that time, they also made their second ambulance a full-time ambulance, year-round ambulance. So they did some changes to our delivery system to accommodate for those longer transport times that were expected. During COVID, when we look at and monitor our response times and see that they didn't change during that period, and part of it is because of our move up and cover system, our depth of resources. But more importantly, we have constant staffing, which means that the city of San Clemente has 3 paramedic units, 2 paramedic engines, 1 paramedic truck every day, with 2 paramedics on it every day. What that constant staffing means is when people are going home sick, when people are off on
A follow-up question on that. So the response time is when you get on site with wherever the emergency is, right? That's the metric we're measuring?
Yes, it's from when the call's entered by our dispatch to when that first engine gets on scene.
Okay. And then do we have any data on transport time? So how long it takes from the time you leave the site to get to various areas? I'm just kind of, again, I'm looking for any sort of data we may have or metrics around that. If you're going to Mission Viejo, or you're going to Laguna Beach, for example.
Yeah, I don't have transport time data in front of me. Tammy, is that anything that you have brought with you?
I don't have the data, but anecdotally, just know, depending upon the traffic pattern, the transport time is probably between 10 and 15 minutes. And that's also dependent upon if they're going lights and sirens.
Okay.
You know, one of the things I want to point out that I think in the future, what we're going to see is less emphasis on response times. And I know this is something difficult for the public to understand, and even myself as a parent. If I call 911 because my child is hurt, I want them to get there as soon as possible. And waiting is just unbearable. But what we find in the actual clinical data, there are very few medical conditions, emergencies that actually require, you know, a very quick lights and sirens response and transport to the hospital. But it's very hard mindset to break when you're on the other end of that as a patient or parent, because waiting is just unbearable. But I think in the future, response times is what everybody can understand. It's quantifiable. It's an easy metric, but there are risks to getting to a scene and getting to a hospital faster. There's risks to the crew, the patient, and then the public that's on the road. So I just wanted to make that point. It's not going to happen in the near future, but there's a lot of literature out there saying that it's really the benefit outweighs, or the risk outweighs the benefit of traveling that fast. But it's going to take a while to break that mindset.
So I think I'll interpret what I think I hear you saying, and then Tatiana can completely correct the record and offer her perspective. But if I have broken my wrist, I'm in immense pain, and I'm in immense pain, but I'm highly likely not going to die if it takes an extra 5 minutes. And whereas the ambulance that's responding, or the paramedic with their lights going and they're ripping through red lights and trying to get there, the benefits of getting there that fast aren't worth the risk to human life, both for the occupants of the paramedic unit as well as the public who may get into an accident with that particular unit. Is that kind of what you're describing?
Correct. And it's not that the medics are going to be heartless and just drive slow. They have a toolkit. They have medication at their ready to provide that. Okay. So it's not like you won't get treated.
Right.
That's a different situation.
Well, as I feel I constantly have to remind the world, life is, there's cost benefits to everything, and you need to understand those cost benefits. And it's not all about money, but sometimes money can be a helpful measure of looking at these cost benefit considerations. And that's where we enter the public policy discussion, in my experience. Tatiana, you had your hand up. Love to hear from you.
You know, I want to support Tammy and build on what she just shared with all of you. And I think we see the technology playing a huge role in that as well. So in the past, Technology can and will help us to identify and breach sometimes that anxiety, especially Tammy mentioned parents and children. We're seeing telehealth and our digital cameras. You know, think about the future that if something happens and it's an emergency and you perceive that you need to get care right away for you or your loved ones or anyone else, and you have digital means, whether it's a wearable that can tell you whether your blood pressure or something else going up to the degree that you need care now, 5 minutes or 10 minutes from now. You know, you have a digital phone. Most of us do have, you know, some kind of digital means or people around us where you can send a picture or even FaceTime with your care provider so they can talk you through what needs to be done, not only on the phone now, but visually as well. And it's a two-way stream. It's two-way information. All of this technology becoming less expensive, better and better to use for medical professionals. I can see in the future, and we're already seeing that, you know, for example, UCI Health working with Dispatch Health, which is basically acute care at home. You have a transport team that comes out. There is a feed, you know, into the hospital, into the care teams. Sometimes patients stabilize, sometimes they're transported to home, but sometimes you don't need that level of care because, you know, you might feel that you do. You know, the story to tell you, I have a child, I have a son, and probably as most of us parents, you know, he felt when he was playing and he cut his eyebrow. And as a mother, and I'm in healthcare field for 20 years, right? I'm not a healthcare professional, but looking at this, I panicked. I called the emergency rooms, I called ED, I almost called 911. We took him to the hospital. Now looking back at this, if I could just FaceTime someone and show his wound, they probably would tell me it's all right, you know, just put the pad on it, everything's going to be okay. He might not need, you know, wait for 5-10 minutes, see what's happening. So all of this could have been prevented, including my own anxiety, right? Not only being a good stewards of our resources, but technology gets cheaper, medical professional adopting it, and I do see us getting better in using it to make sure that Tammy and her teams only come to the right patient, to the right consumer at the right time.
Interesting.
And Ryder, I'd like to add on one more thing to that. I completely support Tammy and Tatiana on their statements. But what's important to us, and we've been able to maintain it, is those times, although it's not as frequent as those lower priority calls. But when you need a rapid response, you need to have an adequate resource and a resource system to be able to get resources to that incident. And so that's where our efforts goes, to make sure that those resources are available for when that happens. And you could say the same thing for a fire. As years go on with a strong fire prevention program, number of fires have gone down. But when the fire occurs, you need to have adequate number and an adequate response time to deal with those. So, but I do agree with Tatiana and Tammy as well.
Yeah, understood. Mayor James, I see your hand up.
So our time is limited, and there is a question in the question window that we're talking around the edges of that question, and so I'm going to pose the question for the person who posed it. What stats are available from start of transport time to what time patient is accepted by receiving facility? This is a critical statement in evaluating emergency services in San Clemente. So is there data out there, and I'm following up on the question, is there data out there, and is there data as to if that 15-minute window had any impact on the patient's delivery of care to that patient? I think that's for Rob and Tammy.
I'll take a stab at it. I don't have the specific data for San Clemente, but anecdotally, the transport time's 15 minutes. I'm going to pull up the question. So from the time 911 was called, 15 minutes, 6 minutes, And then you get to the hospital, and let's assume that you're seen by a provider within 10 minutes. We're talking 30 minutes. The hospital's required to, and what happens is they have to balance competing priorities, competing patients. And so they go through, obviously, a system of triage. And you know, the fortunate thing with ambulance patients is there's already a tremendous amount of data that has been provided to the emergency department prior to the patient even getting to there. So they know the vital signs, they know a general acuity level of the patient, they know whether or not they need to take that patient directly off the ambulance gurney into an ER bed. So even before the patient gets there, there's some decisions being made. So I don't have the numbers exactly, but I would say it's within 30 minutes.
And Tammy, I suspect that you, when you say you don't have the numbers exactly, it's just you didn't have them prepared for today,
Right.
but some of this data does exist. So we can perhaps have it pulled for our next community forum discussion and have some of that data available as part of just the bevy of information that we would look to have in some of this situation.
And Tammy, offline from that, if you could get that data to me and I'll get it to the person who posed the question. Thank you.
Just to clarify though, wouldn't the most at-risk people, and I think we said it was ALS, acute, sorry,
Yeah.
I can't remember what that,
Acute life support.
Advanced
folks-
life support.
those folks were already going to the trauma centers. They wouldn't be going to the community hospital anyway, right? Isn't that generally correct?
Correct.
So I want to ask if there was a question here about, I mean, effectively was, you know, kind of the threshold question is, should every city have a hospital or emergency room is actually the question. And I want to tie it in with a prior comment that, or a comment and question that was made, which is that there's kind of some regional questions to be raised around hospital support, because the reality is all the cities around you have been growing too and creating more demand in South Orange County. So I guess I would be curious, particularly from maybe the Hospital Association and UCI Health, like, do you, at what point does a market respond to seeing increased overall population and therefore finding means to actually create a hospital, right? So if it's not just focused on San Clemente's needs, but needs for that new Rancho area that's exploding out there, that's under development right now, and continuing San Juan Capistrano population growth. You know, how do hospital networks look at opportunities to go into markets, and how do they evaluate that? So that's a question for Paul or Tatiana. If you could just comment on like market development considerations.
Yeah, do you want me to start kind of to get my perspective? And maybe my perspectives will come also. I've been working in multiple states, multiple markets as well. Some of it applicable to us in California and some of it is slightly different. I think Paul mentioned regulatory environment is very, very important, but it's also overall trajectory of the healthcare and how services delivered. So maybe in the past, I would say, I think the 2010 was mentioned, maybe that's that Goldilocks year when we thought that the answer to communities' healthcare needs would be another hospital. Bigger, smaller, 50 beds, 100 beds, 500 beds, you know, depending on, we have our metrics. We would look at demographics, population growth, et cetera. What we do look now is how do we deliver healthcare? How do we answer healthcare needs the best for the community? With all the needs with all the innovation that we have, whether it's ambulatory space, what's the most convenient, safest, and the best outcome for a patient? So when we look at the community and we see the need, we not necessarily think right away, we need another hospital for multiple reasons, right? The cost, the delivery, is that how do we deliver care? So the question becoming more and more complex, because what we don't want to do is to basically develop a building that will be highly regulated, very costly, and probably not necessary. And then it's becoming obsolete in 5 to 10 years, right? So we are, as multiple panelists on this panel already mentioned, we'll look at what are the community needs and how best with our modern technology, with our access to the community answer those needs. I hope that makes sense.
It does. I mean, I think what's interesting is, when you're a hammer, everything looks like a nail. If you only start with the assumption that the hospital is the only solution, then it kind of changes up the framework of the discussion, when it sounds like, and maybe Paul, you could comment on this because you represent lots of hospitals. The trend is that hospitals, I want to put, I guess to some extent, hospitals are not like a growth market, right? Like that's not where the big focus is. They're obviously critical. Like that's not to clearly what your members do is important to communities. But it sounds like, are you seeing a downtrend in the pace at which hospitals are being developed? It's not really keeping up with population California in general. And is that reflective of all these trends we've talked about?
I think in the Western region in general, that's the case. I mean, if we look at bed supply in the West, and you're talking Washington, Oregon, California, and even Hawaii, not a lot of beds. I think, we're compared to other regions like, say, the Southeast, a lot of beds per capita. It's a different care model. I think I'd like to think that California is very, very innovative in the sense of trying to figure out because we have things like the UC system, right? We're looking at trying to develop more outpatient-based care. You look at the fact that healthcare already consumes almost 20% of our national GDP. I don't think we want to consume more. And selfishly, from the association's perspective, heck yeah, we'd love hospitals. We'd love to expand our membership to, we've got 180 in our 6 counties. Of course, let's get to 200. Why not 300? But it's not feasible. I mean, you look at the number of hospitals. I mean, in terms of general acute care hospitals, I looked at Orange County. In terms of occupied beds, it's 53% right now. We're actually over-bedded, if anything, right? So we don't even use all of the beds that we're technically licensed for already. So to develop another general acute care hospital just doesn't make sense. Where's really the need? Probably acute psychiatric hospitals. Behavioral health is really where the need is, but I'll tell you, from a NIMBYism perspective, not in my backyard, we have, very, very few communities are willing to have an acute psychiatric hospital open up in their backyard. But that's where the need is, right? Psychiatric beds is really what mucks up our ED system and everything else. I mean, it's the lack of behavioral health care. That's really, if you want to kind of point to need, that's kind of where the healthcare system needs to go. I see Tatiana nodding her head.
Just want to throw support towards inpatient psychiatric need that we're also seeing from, at least from UCI Health perspective, significant need in the communities and across the country too, but for us, definitely an acute need. And then I just want to go back to that identity. And Paul mentioned, I think hospitals are no longer buildings, right? So when we look at ourselves, when we're saying hospital, right, it's no longer that buildings that we used to be 20 years ago. We're health systems that have hospitals as part of our answer to the need of particular community. And I don't think we will continue being members of Paul's association, even if we look slightly different, right? And we have other solutions where we're trying to get cost of care more convenient, a little bit less expensive, but preserving the quality. So it's more of an identity. So when somebody asks, are my healthcare needs met in my community, the hospital building not necessarily the answer, but the right level of healthcare delivery is. And it doesn't look like building.
Right. I know we're running a little tight of time. If it would be at all possible, if our panel members have to go at 11:30, please feel free if you have to drop off. You give me just 10 extra minutes. There's just a few other community questions here I want to try to accommodate that. We're not going to get to all of them today. We had a bunch of them come in here. There's a related question here, and I know this kind of strikes against the very point we were just making to some extent about what is the definition of hospital. But Jaden S had asked, is there a minimum proximity in miles or minutes that's best for residents' access to a hospital? And are San Clemente residents ever in danger if there's not emergency care, say within a 10-minute drive? And I'll defer first to our health policy experts on that if they have some thoughts about that, because there's obviously a geolocation question that comes up here. So
I want to say, in terms of what's called network adequacy, And the regulations typically are like a 30-minute, I think, is what they use in terms of a standard. So if you're looking, particularly if you operate a health plan, right, they've got to have some kind of contracted provider within a 30-minute kind of geo radius.
Okay, so that's the expected, that's the defined state standard. I think we could probably all acknowledge that there are always use cases where speed is important. I think Tammy shared some data around that, but the vast majority of cases she noted, timing was not really as critical. There might be a critical need and urgency is what I heard, like screaming child in deep pain. Yes, as a parent, you viscerally want to respond to that with immediacy. From an actual tactical outcomes perspective, doesn't necessarily make a big difference. Is that a fair summary of your comments, Tammy?
Yes.
Okay. And then, and I guess to the point, we would also, from our healthcare experts, you would acknowledge like there are certain cases where yes, getting to a hospital room, an emergency room, 2 minutes, 5 minutes faster could actually be significant to the outcome of a particular circumstance. Is that a fair statement too?
Absolutely.
Okay. So I think to maybe the Jade Ness question, the answer is there will always be some percentage impact. It's probably in those particular acute areas that maybe that's not the right term. My apologies, Danny, but that you had noted before, like there were about 130 roughly strokes and heart issues is I think what you addressed. I would assume those tend to be time sensitive.
Yes, but what we're seeing is there's a little bit more time than we thought that we have to actually get those patients to definitive services. So the obvious ones are being unable to breathe or bleeding. So there's always going to be the need for emergent, as quick as you can get their responses. My point is that we've been able over the years through the science to figure out a way to narrow that down to a specific group of illnesses. And then with the training of the paramedics, that's that check and balance of, while we might think the dispatch is one thing, they get there and realize, oh, there's way more going on or way less going on. And then they have the judgment and the decision-making ability to determine, how fast you get there and what you do in the meantime before you get to the hospital.
Awesome. Question for Mayor Pro Tem. How many Donna V asked this question. How many RFPs did the city put out to seek an investor in San Clemente Hospital? And when was this done?
An RFP was put out in, I believe, January 20, it was January 2020. And it was sent out to as many providers as we could conceivably identify. So it was just one RFP, but it reached out to a large universe of providers.
And almost no one responded. Well, actually, nobody responded with a firm commitment. One group asked for essentially follow-up. We followed up with them. Then we affirmatively went out there and went to a bunch of hospitals and said, hey, you didn't participate in the RFP. Are you interested in a hospital in San Clemente? And like we've said over and over again, we got a very tepid interest, if any. And I just want to close out the last point. And I don't want to start a whole new discussion point, Ryder, but
don't ruin my mojo here, buddy.
The issues of taking individuals to some sort of medical facility short of a trauma center. There is legislation out there. There is a movement to allow for greater flexibility amongst our fire folks so that we could potentially see in the future, and maybe it's not the immediate future, but in the future, the ability to deliver individuals to other types of medical facilities that San Clemente might have, short of the hospital model. And I just want to throw that out because that's something to consider here as we move forward with what we are going to be able to get to San Clemente. But yeah, but I think we've addressed the point.
All right.
And if I may just follow up on that question. So the one legitimate entity that did respond to us was the Palomar Healthcare District. Former council member Ham and I both went to Escondido, took a tour of their newest hospital, had a great dialogue with their staff, but at the same time, there would be an expectation that we would build the hospital, we would underwrite the hospital. And this is a healthcare district that's in the best case scenario is 45 minutes away from us. And, you know, then there would be the question if patients had to be transferred, would they be transferred to their facility in Escondido at some point in time for follow-up services, you know, which is usually Escondido's an hour away. So that was the one legitimate entity that did reach out to us, and we have had dialogue with. But that's, other than that, nothing. And you know, we've not only did we throw it out there, we've actually reached out to others such as UCI. Are you interested? UC San Diego. Are you interested? Scripps. Are you interested? Hoag. Are you interested? And the answer was always the same.
Yeah, and I think my perception is that's not a you know, given the innovation that's going on in the space, it was understandable that their answer might not be they were interested, right?
Yeah, there's no judgment on their answer. Their answer was based on sound business principles.
There were a bunch of questions we had submitted here from Anonymous inquiring about the future of the Memorial Care site and its closure. And I just want to note that I would refer folks to the website itself, where our city website, where we have a bunch of answers to questions specific to that site. We weren't really specific to what we were going to do with the future of that site. They have a plan that they've submitted to their property that's going through the standard process in the city of San Clemente for any sort of major project planning. And as a result, our mayor pro tem also really can't comment on it because at some point they will probably be in a position to have to vote on the matter. So they're not going to make comments on it. And I don't think anybody else on this panel is particularly well positioned to make comments about what the future of that property is. But we do have information in what they've submitted as public record that is available on the city's website. There is a question about over the past couple of years, how many patients do we know, or do we have access to data about how many patients might have had to divert due to overcapacity at the nearest hospital? And on average, how much extra time does the divert take to get the patient to the ER? So I know, Tammy, this goes back to some transport data, which we don't have immediately available. We can pursue. And obviously, I would just make an observation. Seems to me like the last couple of years, COVID has really kind of skewed up a bunch of numbers. So it's difficult to discuss what this really means. Although I'm pretty sure, is it fair to say we never hit 100% capacity at either of the hospitals in South Orange County?
Oh, I think we did, but they managed to find beds in different locations and implement those. But I can actually answer the question because we do a fair amount of research on this. And yes, COVID skewed a lot. We had unprecedented responses and transports, the highest ever in January of 2022. But in years between the San Clemente closure to before the pandemic, what we look at is diversion data very closely. And what I want to point out is that prior to the closure, Mission knew they were going to get the majority of those patients. And so they actually added rooms and they expanded capacity of their ER. So how we measure it, while I don't have the number of patients, what I do is the number of hours. So they're allowed to go on diversion no more than 2 hours at a time. And so for one example, in 2020, the diversion for Mission was 20 hours for the whole year. So that's not a large amount of time. And if you just say that in an hour, Mission would see about 8 ambulance runs, and not all of them are coming from the San Clemente area. I could presume that it was less than 10 patients. And then the second part of the question was then if they were diverting, it doesn't add, the time that it adds is the paramedics and the ambulance people know before they leave the scene whether or not that hospital is diverting. So they're not going to waste time driving to that hospital only to find out they're diverting. So they know ahead of time. So I would say it would only add 5 more minutes to their transport time to go to the next closest, most appropriate hospital. And what I want to add on to that question, if I may, is that I think it's important to note that the transport times for the most acute stroke cardiac trauma patients, those have not changed since the San Clemente closure. Those are the highest priority, and those, and Rob can back it up with his stats, but those transport times have not increased because those patients were already going there.
Right, fair point. And an important one. I think there's a lot of concern around those particular scenarios. And as a 48-year-old male who will someday be older, I will be highly concerned about that. Me and my Lipitor. So the next question, I guess one last question I'll just throw out here. With current and new Providence, this was asked by Anonymous, current and new Providence Urgent Care and large healthcare center, and one proposed by Memorial Care at that campus, won't that have a big impact on patients needing immediate care? So I think this maybe speaks to some of the innovation model we were talking about. And obviously, I'll throw it to anybody, member of the panel, to talk about that. But I suspect Mayor Pro Tem, one of you may at least have some initial thoughts on that because you're familiar with some of these developments that are going on from Providence and at least some of the publicly available information from Memorial Care, without speaking to the Memorial Care project specifically.
I'll just take it first, Gene. So yeah, I'm not going to get to talk about the Memorial Care property, but there's a sort of super urgent care, right? Or it's not a technical term, but that's planned for the outlets. This goes to the earlier point I was talking about, which is, are there other medical facility models that meet the needs of the community short of a hospital? And if there are, then how do we explore that? That may be part of the answer, that type of facility. Or maybe you need multiple of those types of facilities in San Clemente. And the other point is that the technical term is community telemedicine. Again, is this concept of shouldn't we allow our firefighters, who, by the way, do a tremendous job in San Clemente. It's part of the reason we codified the fourth firefighter, and certainly understand the points they're making about wall time and having to go to the trauma center. That's why we were looking at the hospital, frankly. But isn't there a model where we can have these services provided by something else other than a hospital, and even deliver people that have paramedic services, that are in need of paramedic services, to these things? Let's look at legislation like that. We should have legislators working on things like that, don't you think, Gene?
I agree.
And
agree.
yeah, and so I think that's the future as we look at these different models. I think that will happen, and we should be prepared to take advantage of that. That's my perspective on it. But I think that type of facility that we're looking at the outlets is something that I think we're going to be seeing more of. I think our resources are best put towards looking at those models that actually are going to be coming into the city.
Okay.
And Ryder, in regards to your last comment about your Lipitor, as a 67-year-old who eats pork and or beef 3 times a day religiously, my cardiologist's wife tells me it's not if, it's when for me. So I hear about what you're saying. You know, we just cannot look at healthcare as being static, a static service that's existed generation after generation. I really love the comment, the one thing we don't need is an unneeded, overregulated building. That is going to stick with me. The fact that we have a downward trend in inpatient service, in inpatient census, it should be something we should all look at. The fact that 40% of the hospitals in Southern California are in the red. That is one more thing that we have to look at. We have to look at healthcare going into the going into the mid 21st century and beyond. And what does that mean? And maybe you're going to be a patient, but you're going to be in your bed at home, you know, and monitored by healthcare professionals remotely. There's a lot of things going on. There's a lot of, you know, if you go around the county and look at some of the really super impressive Uber urgent cares and the whole comprehensive concept of not just urgent care, but holistic health as well. I think that's what we have to look at in San Clemente. That is what we need to be focusing on, not encumbering our taxpayers with, at the very least, a $200 million obligation that could very well be undercapitalized.
Okay. Thank you, Mayor Pro Tem, and all of our panel members. This has been I've learned a lot today. So I thank you. I want to give Tammy a gold star for being the most metrics data-driven person on this call. It's bravo, Tammy, good job. Queen of metrics. But this is all super healthy perspective. We have policy leaders, we have immediate transport people, providers inside the community of San Clemente, and we have some global perspective from our healthcare experts at UCI Health and the California Hospital Association of Southern California. Thank you all for your time this morning on this. Sydney, if we could go full screen real quick with our 2 concluding slides, because while we're wrapping up this presentations, this is not the end of the conversation here. So first of all, we are doing well, actually, Mayor, you want to talk about this upcoming roundtable we're going to be doing?
Certainly. So 2 weeks from today, April the 23rd at 10 a.m. at the San Clemente Community Center, we're actually going to have a second round of discussion with our local experts, local doctors, who will have different points of view in regards to healthcare going into the future in San Clemente. It's going to be a continued engagement with the community, with a community roundtable. And I would just like to finish off, excuse me.
Do we need to dispatch a EMS to you right now, Mayor?
I did a self-Heimlich, I'm good.
Okay.
I would like to conclude with what a super panel we had today. I have a lot of great things I've learned today, and I would like to thank every one of them. And the 31 participants that we have still with us, I think we only lost 7 throughout the hour and a half. Thank them as well. Thank you, Ryder.
Thank you, Mayor. Appreciate it. And if we go to the final slide, just to note that this conversation, even if it's not happening either in person or today for you, we would encourage you to visit san-clemente.org/hospital or email healthcare@san-clemente.org to remain in contact with us, express your questions and concerns, or to stay informed about what's going on with healthcare and hospital services in the city of San Clemente. A really important part of the conversation. We look forward to continuing on this complex subject. And again, I can't thank enough, not only for the public participation day, but our amazing panel members. So you all have a great rest of your Saturday. Enjoy it, well earned, and we'll see you at the next community forum.
Thank you, everyone.
Thank you, Ryder.